Hi and welcome to part 2 of Pharmacokinetics, where we're going to finish off looking at absorption and also look at bioavailability of remedies. So continuing on the theme of factors affecting gut absorption, gastrointestinal motility will affect it. This can be monitored by stool transit time or to some extent the bowel opening frequency. If we say somebody has a speedy digestion, then they will have a lower absorption rate for therapeutic remedies. And likewise, if somebody has a sluggish digestion, if they have a tendency towards constipation, they will have a higher absorption of the constituents of the remedies because they've had longer to sit in the gut and be absorbed. Malabsorption can interfere with remedy absorption, perhaps due to lack of bile or pancreatitis, mucking up the juices being secreted into the intestinal tract, or physical damage to the intestinal villi. And this could be due to celiac disease, gluten enteropathy, where there's a destruction of the microvilli, quite drastic sometimes. Even a history of anorexia can have done some permanent damage to the structure of the gut, therefore upsetting absorption. Of course, a big impact will be the intestinal flora. Strictly speaking, we should call this microbiota, not flora, because there's no plants involved. It's bacteria, yeasts and protozoa. Bacteria being the most important in this respect. Many remedies are metabolized by the gut microorganisms, so they can, for example, affect glycosylation of remedies and therefore lipid solubility. So if you have like a cardiac glycoside, then you digest off the sugar, you've got a much more lipid soluble compound which can then pass freely across the intestinal wall. Changes in the microorganism population will have massive effect on the absorption of remedies. So for example, gut dysbiosis after antibiotics. There is histological variation. People have different tissues, their intestinal tissues are different, so there will be individual variation in the rates of absorption. This might be characterized by the degree of expression of carrier molecules, so the number of carrier molecules that are on the outside of the cells, and inside the intestinal cells themselves there might be a different metabolic pattern. So on to bioavailability, and that's linked to absorption, but what do we mean by it? Well, here's a definition. Bioavailability is the extent to which an active substance in a medicine reaches the bloodstream and target organs after administration. So the idea is we can administer a drug or a remedy, but if it's not bioavailable, then it's never going to get into the bloodstream. When we study the pharmacology of herbs, mainly we're studying the actions of constituents. This is by in vitro experiments in a traditional test tube, but increasingly in plastic really. But this is where you have a direct introduction of the constituent to target experimental cells in reaction vessels. So there's no barrier between the introduction of the constituent and the cells themselves. Where experiments are in vivo, in other words in living situations, living organisms, it's still fairly artificial because the constituents often introduced direct into the bloodstream by parenteral injection or infusion. So you might have like a drip sort of gradually infusing your substance into the bloodstream of the test animal. So neither of these is going to mimic what we see in real life with clinical practice. So it's quite difficult to extrapolate accurately what the clinical situation will be once you start to use remedies on patients. Because if we have an oral administration route or a non-invasive administration route, it might not deliver the constituents into the bloodstream at all, or if it does, they might not be in the same form. So pharmacological studies might discover really potent actions of constituents, but that may not translate to the clinical situation when we're using whole herbs and they're having to be absorbed through the gut. So they're just not going to be as bioavailable. So that's kind of the downside. The plus side is that when constituents are found to be toxic experimentally, this may be much less true clinically, again because of bioavailability issues. So for example, tannins and saponins are less likely to cause catastrophic effects in the bloodstream if given by the gastrointestinal route. So what kind of constituents, what kind of molecules have poor bioavailability? So very large molecules, obviously harder to absorb because you've got to shunt them across the membranes. So tannins, old terminology, proper, more up-to-date terminology would be high molecular weight polyphenols. Much easier to say tannins, really, isn't it? But tannins have a low lipid solubility, and they also tend to bind to proteins in the gut lumen, so they're not very easily absorbed into the bloodstream and into the other tissues. Also, polar molecules with a non-ionic moiety and an ionic I can't even say the word, I don't know why you even put it there, but one part of the molecule is non-ionic, the other part is ionic. So for example, triterpenoid saponins, these are often present as glycosides, and also the cardiac glycosides. In that form, as the glycosides are not very bioavailable. And as we've hinted to before, microbial action will make them less polar, chomp them up into aglycones, and then they're more easily absorbed. And this is an issue with some endogenous compounds as well. So for example, bile salts are basically cholesterol with a salty bit stuck on the end. If bugs jump off the salty bit, then it's much more easily absorbed. So you have a cycle, a cholesterol cycle, constant reabsorption, a gastrohepatic cycle, or a colohepatic cycle. That will be true of a lot of steroidal remedies as well. So that's certainly famous for the cardiac glycosides in digitalis. That digitalis isn't simply just excreted and that's it. There's a cycle where some of it will be reabsorbed and secreted again, and so on and so forth. So they can persist for quite a long time in the body. The sort of things that are easily absorbed. Well, obviously lipid-based constituents, because they can just kind of sort of squirt straight through the cell walls. Volatile oils, so a lot of the constituents in mentha, piperita, thymus, these are easily absorbed in mouth and stomach, let alone in the intestine. In Chamomilla recitata, the flavonoids, antioxidant flavonoids, will be absorbed easily into deep layers of the skin, so they won't just sit on the surface, they'll penetrate right down into the deeper layers of the skin and have their soothing anti-inflammatory effect. The sesquiterpene camasculine that you find in chamomile is absorbed readily in the stomach after hydrolysis of precursor molecules. Other non-polar molecules which are easily absorbed include flavonoids. Well, we mentioned that a bit with chamomile, but for example in clover, Trifolium pratense and Crataegus, hawthorn. The naphthodianthrones, for example hypericin and hypericum, that's very easily absorbed. Flavonolignans like psilocybin and psilocybin will be quickly absorbed, and terpene lactones of ginkgo, for example. These are all easily absorbed. So a lot of these things will be absorbed from the mouth. So if you sort of make if you have a tincture or a tea, then the absorption will begin in the mouth. So drops on the tongue will be effective in some respects. A-glycones, as mentioned before, will be absorbed. These are plant glycosides after the removal of the sugar moiety by, I'm going to say it that time, by intrinsic degradation or by bacterial action. So, for example, in licorice, glycyrrhetinic acids is the A-glycone from glycyrrhizin, and that will be the GA will be more readily absorbed than the GL. And convallaria, similar to foxglove, digitalis, the convalicides are absorbed in the A-glycone form. So again, you probably need a good gut flora to get the best out of these remedies. And that's me with absorption and bioavailability. Next chapter will be on remedy distribution.